I guess one of the reasons why I really became interested in pregnancy myself was because of this paper that we published back in 2016. And we didn't really set out to look at pregnancy per se, but we were really interested in identifying predictors of long-term disability outcomes. And so the first thing that we looked at was change in these disability scores or EDSS scores over a 10-year period. And what we actually found was that the median EDSS score increase in MS is only about 1 disability point over 10 years. So EDSS scores don't tend to change terribly much over a decade. But we still wanted to see what predicted this. And so when we looked at our predictive models, again, we found that relapse activity was the one strongest clinical predictor of disability outcomes in the long term. But we also intriguingly found that women who had pregnancies tended to have a lower disability score than women who did not. And when we looked at this in a little bit more detail, in a slightly smaller cohort, we found that cumulative time on disease-modifying therapy was associated with a reduction in disability score over a 10-year period, but pregnancy had an almost 4-fold more potent effect than first-line disease-modifying therapy in terms of preventing disability progression. So this was really intriguing to us. So there's a bit of a paradox here because women have been shown to be more susceptible. It's been shown that there is an increased sex ratio of women to men with MS. But interestingly enough, women have also been shown to have a better long-term prognosis on the whole than men have. And so the question is this due to sex hormone variation? So the best evidence that we have for this hypothesis actually comes from a study that was published back in 1998, looking at the effect of pregnancy on relapse activity in women with MS. And this was really a seminal paper because prior to this paper, women were historically discouraged from having children because it was feared that it might exacerbate their disease course. And what this study showed was actually when women were pregnant, their relapse activity decreased and was lowest in the 3rd trimester, met by a relapse rebound after delivery. And this work has now been replicated by a number of different groups. We published a meta-analysis earlier this year looking at how relapse activity changes over the pregnant period and over decades. And so we compared historical data to more modern data, and we were able to show the same pattern that relapse activity does drop during pregnancy with a relapse rebound postpartum, although you can see in the most modern data that this curve has flattened out a fair bit. And again, in a paper that we've submitted and some work done by an amazing honours student that I had last year, Yui, we again did the same thing with data from the MS-based registry, comparing relapse rates in women with MS during pregnancy, or both before pregnancy, during and after. So in order to do that, my group collaborates with the MS-based registry, and some of you might have already heard about the MS-based registry from Helmut Butzguven, who's a head of department and is the managing director of MS-Base, or from Annika, who's the COO of MS-Base. For those of you that aren't familiar with it, it's a clinical outcomes registry that prospectively collects clinical treatment demographic data on people with MS from all over the world, as you can see from that heat map. There's an agreed minimum data set, and it started back in 2004. So for some individuals, we've got about 16 years of prospectively collected clinical outcomes data. Some of the work that my group is undertaking at the moment is to really try and interrogate what impact pregnancy does have on long-term prognosis. And this is not only in women with relapsing remitting MS, but also in women with progressive MS, because there's no published papers on this at the moment, because very few women with progressive MS do have pregnancies. So we're making a huge concerted effort at the moment in order to collect this information. And we've got almost 4,000 women to date surveyed. So hopefully we'll be able to start to address this question. The other question is to do with timing. So as I indicated before, women who are over the age of 35 are less likely to have a relapse in pregnancy. And that's because we know that inflammatory activity diminishes with time. And so the question is, if pregnancy is beneficial for women with MS, is it to do with timing or the age at which women do have that pregnancy? And one of the other things that we are now also working on is to prospectively assess fetal and neonatal outcomes in babies born of women treated with disease-modifying therapies. Now, on top of this minimum data set, the MS-based registry has always collected pregnancy information. But just in May, so a few months ago, we were really pleased to be able to launch a new pregnancy register within MSBase, of which I've got the privilege of being the co-chair and scientific lead. And here we are collecting a lot more detailed information than was previously possible to collect. So what has MSBase shown us about pregnancy in a modern era? So this is a study that we published last year, and what we demonstrated was that in women of childbearing age, the trend towards staying on MS therapy until a pregnancy has been confirmed has really increased over time. And so in 2016, we were able to show that about 62% of all pregnancies in women with MS are conceived whilst on disease-modifying therapy. This is actually counter to what used to be advised, which was that women should discontinue disease-modifying therapy in order to become pregnant because of potential teratogenic risks of these disease-modifying therapies on a fetus. And this study really is consistent with work from other countries, including the German Pregnancy Registry and Brazilian data, which have also shown this increased trend to treat women with MS with disease-modifying therapies until a pregnancy has been confirmed. This is work that was done by our PhD student, Wei Yi, and he looked to see whether or not disease-modifying therapy use in pregnancy, or how disease-modifying therapy use in pregnancy impacts disease activity. And so what he has shown in work that he just presented at ECTRIMS last week was that women who have mild disease and therefore are not on any disease-modifying therapy or are on low efficacy disease-modifying therapies, they still have the same trends as Controverse showed back in 1998, which is to say that their relapse activity decreases with a trough in the third trimester to be met with a postpartum relapse rebound in the first trimester postpartum. But interestingly, those women with more severe disease, those treated on higher efficacy therapies, they no longer have this reduction in annualized relapse rate through to the first trimester. And if anything, we see a rebound in disease activity as therapy is withdrawn. So predictors of relapse in pregnancy in a modern era are use of high efficacy therapy prior to pregnancy. So in other words, women who have higher disease activity to begin with are more likely not to derive benefit from pregnancy. And also annualized relapse rate in the year pre-conception. So again, demonstrating that women with more active disease are those that are most likely to also continue to have disease activity in pregnancy. But he also showed that continuing high efficacy therapy into pregnancy is able to prevent relapse activity, and also that older age is associated with a lower risk of relapse in pregnancy. But what impact does pregnancy have on short-term disability progression? So he also looked to identify what factors might predict short-term disability progression in the context of pregnancy. And there's only one historical study that previously looked at that, and that suggested that about 12% of women who had pregnancies that their pregnancies were followed by short-term disability increases. And happily in Wei's paper, he found that it's only about 5.6% of pregnancies now end with a confirmed disability progression event afterwards. And the two main predictors of disability progression were, again, relapse activity in pregnancy and postpartum relapse activity. So again, demonstrating that relapses are predictive of progression, and so they're a poor prognostic factor. We looked at 2,600 women who we surveyed about their entire pregnancy histories. And so what we did was we looked at women within the MS-based registry who did all end up going on to develop a clinically isolated syndrome and MS. And we surveyed them about their entire pregnancy histories. And they were incredibly generous, sharing with us a lot of personal stories, because we weren't only interested in pregnancies that were resulted in live births, we were also interested in all pregnancy histories, including miscarriages and abortions. And so this is a picture of Ailan Nguyen, who's one of our PhD students who did this work. And so what she did was she modelled pregnancy as a time-varying covariate and looked at the age at which women who had a pregnancy versus those that didn't developed a clinically isolated syndrome. Now, the reason why we're interested in a clinically isolated syndrome is because once a woman is diagnosed with MS, she may change her reproductive behaviour. If you know that you've got a chronic health condition, that might change your thoughts about having a family in the first place. So we wanted to look at pregnancies before the first symptoms of a clinically isolated syndrome in order to remove some of that indication bias that might occur. And so what she was able to demonstrate in this paper is that having a pregnancy can delay the diagnosis of a clinically isolated syndrome by 3.3 years. And then if we looked at parity, so actually having a live childbirth, then the delay was only 3.4 years. So there wasn't too much difference in terms of the delay. So any pregnancy, irrespective of the length, was able to delay the onset of the first symptoms. When we looked at the number of pregnancies and whether or not there's a cumulative effect of pregnancy on the delay to a clinically isolated syndrome, we actually found that there was no difference in terms of the number of children born and the effect on delay of disease onset. So this is counter to a number of different studies that have been published in the past, demonstrating that there's something interesting going on, that there is no obvious cumulative effect here. So ongoing work in our group. So we really want to determine whether or not pregnancy does have a beneficial impact on long-term disease outcomes in both relapse onset and progressive MS. And we think that timing is probably everything. And so we're doing a number of studies to look into this. So if it is beneficial, we want to know when and for whom, and really to be able to advise women who do want to start family planning when is a good time to do it, if we can identify that.